Good evening, everybody. I think we'll just give a couple of minutes just to let people join the webinar, and then we'll make a start. Okay, well, it's just after 6 o'clock. I hope everybody's comfortable, and if I could wish you a very good evening. Despite my name tag, I am not Mike Stevens. I am Susan Spence. I'm the Network Manager for the Welsh Renal Clinical Network, and I'd like to welcome you to our second webinar dedicated to the rollout of vaccinations to protect against severe illness that can arise from being infected with COVID-19. I think it's fair to say that the vaccination programme in Wales and across the UK has been very efficient, and it has made a dramatic effect on the overall amount of people who experience poor outcomes from COVID-19. But we do know that in the kidney community, there are many questions, particularly in regard to the third primary dose and the booster jabs. So without further ado, may I introduce you to our expert speakers? And I'll start with the real Mike Stevens, who is a consultant transplant surgeon at University Hospital of Wales. Mike's been a consultant kidney transplant and abdominal organ retrieval surgeon in Cardiff for 10 years, with special interests in organ donation, patient information, consent, and surgical training. He is the Welsh Renal Clinical Network lead for transplantation and vascular access, and he's chaired several programmes of peer review of renal services in Wales. He's also the Deputy Chair of the Welsh Transplant Advisory Committee, who advised Welsh Government on all aspects of organ donation and transplantation. And he's been involved in many aspects of implementing the law change in Wales to an opt-out system for deceased organ donation. This evening we also have Rob Bradley. Rob is a consultant pharmacist for nephrology and transplantation, also based at Cardiff and Vale. Rob has been working as a pharmacist for 25 years, and most of this time has been spent in the specialty of nephrology and transplantation. Rob leads a team of experienced pharmacists and pharmacy technicians who work closely with the multidisciplinary team to prescribe and monitor drug treatments for a large number of transplant, dialysis, and chronic kidney disease patients. Rob's current areas of interest for research and development include medication adherence and prevention and treatment of infections post-kidney transplant. Rob is a long-standing member of the UK Renal Pharmacy Group and previously held the role of education and training lead, which included being project lead for a competency framework for renal pharmacists. So Rob will now be providing an overview of the vaccine programme and providing some myth busters along the way. We'll then move on to a Q&A, a question and answer session. Most of these questions had been posed prior to the webinar, and thank you very much for the range of questions that we've received. But if you have any questions during Rob's presentation, please feel free to use the Q&A button on the Zoom function and write in your question, and we'll try and capture and answer as many as possible as we proceed through the webinar. Okay, so may I ask Rob to step up to the plate and give that overview of the vaccine programme. Thank you.
Thank you very much, Susan. Can everybody hear me okay?
I can, thank you.
Great stuff. Can I have the first slide up, please, Mark? That'd be okay. That's great. Thank you very much. So thank you, Susan, for the introduction, and thank you to the organisers of this meeting for asking me to come on tonight. It's really exciting to be part of this meeting. As Susan said, hopefully, by going through a few slides, I'll ramble on a little bit with the slides. Hopefully, some of the questions that have been posed in advance and maybe floating around in your heads will be answered by the slides. It may even be that some of the slides arouse some more questions, so please feel free to put the questions in the old chat box and we'll answer them after I finish going through these slides. Have the next slide, please, Mark. So I guess, first of all, why are we all here? So we're looking at these Jpvi recommendations. So the Joint Committee on Vaccination and Immunization, as you know, has recently published new advice about what will be the next phase of the COVID-19 vaccination plan. So that'll be the third primary dose for selected patient groups and booster doses for what will be a much larger group of people. And I guess one of the first things to note is the patients given the third dose will also need boosters as well. I think it's quite interesting to think of how many people have actually heard of the JCVI about 18 months ago. I think I was vaguely aware of them, but to be fair to them, they've been always around producing vaccine guidance to direct who gets jabbed with what and when to try to reduce infection risk in the UK, but they're clearly extraordinarily busy at the moment trying to get advice out there. And the next slide, please. Thanks, Mark. So looking at the title of tonight's meeting, my first thoughts are taken back to one of my famous mid-1980s films, The Ghostbusters. Hopefully some of you would have heard of that, and subsequent Ghostbusters 1 and 2 and 3 and whatever. Now, unfortunately, I can't promise you Bill Murray and Dan Aykroyd to come as special guests with their lasers and special equipment for catching and zapping bugs like coronavirus, but hopefully, as you said, hopefully we can answer some of the questions that you have. And the next slide, please. So I think one of the first questions came into my mind really is why is a third vaccine dose needed? I think the sort of basic summary of that will be that some people just don't develop a full immune response to vaccines, and that's something we know about vaccines in general, not just the COVID-19 vaccines. This could be due to their individual illness, for example, chronic kidney disease patients on dialysis, or due to the medications as well. I mean, you may be familiar with, I'm sure you are familiar with drugs that suppress the immune system. These can be taken by kidney transplant patients, those are the anti-rejection drugs, and for kidney patients with autoimmune inflammatory diseases such as things like lupus or vasculitis. So I suppose the summary would be that the third jab, we're going to see that as a big helping hand for the immune system as it works to give you the best possible protection against COVID-19 now and in the future. And the next slide, please, Mark. So what everyone needs on a Tuesday evening is a bit of immunology. Apologies if you're familiar with this already, but I think the immune system is a spectacularly complicated piece of all of our bodies. I know a little bit about it, but not an awful lot. I've figured the best way of summarizing it is to say that we have T cells and B cells in our immune systems, and they will be working together after a vaccine dose is given. That's what's known as the adaptive immune response. And eventually the B cells will produce what you've probably heard of as the antibodies, and the antibodies give us the immune system memory, and they'll protect you against illness if you get infected with the virus in the future. And I suppose the basic idea would be that T cells and B cells will look to sort of seek and destroy any invading microorganisms based on what a vaccine programs them to actually do. And that's a similar response that you'd have to any normal bacterial or viral infection as well. And as I just hinted at, what some illnesses and some medicines can potentially make the T cells and B cells work a little bit less effectively. Next slide, please, Mark. So the immunosuppressive drugs listed there, some of them I'm sure that you'll be familiar with. We have tacrolimus, various brand names, Adaport, Prograf, Advograf, and Envarsus. Cyclosporin, which is the oral brand. And we've got the mycophenolate mofetil, mycophenolate sodium, azathioprine, sirolimus, prednisolone, and then some of the intravenous therapies like rituximab, cyclophosphamide, and eculizumab. So those are all classed as drugs that suppress the immune system in various different ways, and it can include effect on B cells and T cells, for example. And the next slide, please. So again, just going back to the theme of why we're looking at a third dose, I think as Susan hinted at in the introduction, the current COVID vaccination plan has gone very, very, very well. If we look at the population as a whole, that includes all people of all ages, all illnesses. We reckon that there's good estimates that the COVID-19 2-dose schedule gives you about 95% effectiveness, at least, at preventing severe disease, hospital admission and death due to COVID-19. And currently that would include all the various virus variants, alpha, delta, beta, whatever we have there, which to be honest is a fantastic result. I mean, that's probably better than most vaccines, and it's certainly a better success rate than pretty much any of the medicine I could prescribe for you. But, and there is a but here, which is clearly why we're here this evening, vaccines will be slightly less effective overall for kidney disease and kidney transplant patients. At the moment, we can't probably quantify how much that reduction is. We don't think it's a massive reduction, but it is definitely a reduction. Hence the idea of pushing things on with a third dose of vaccine to provide effectively an extra layer of protection. So if we can give that third dose, it'll boost the immune system, for example, to produce more antibodies. So it just gives you that extra layer of protection against the SARS-CoV-2 virus. And I think particularly, as I'm sure you're reading the papers at the moment, it's a bit of an uncertain time with the winter. We're not quite sure how the pandemic is going to evolve. So I think as much protection as we can get for patients is a really good plan, at least for the short term. Next slide, please, Mark. Unfortunately, we don't have a particular test that would tell us which kidney disease patient or kidney transplant patient would benefit from a third dose. We don't have that level of information at the moment. There are clinical trials in progress that will clearly look at the effectiveness of a third dose, and we'll try to look at things like measuring response to vaccines. As you may have read in the press, there are research looking into antibody production following vaccine administration. So that's all ongoing research, which is fantastic. But as yet, there isn't a massive, huge body of evidence because it is such an emerging field. So it's the job of the JCVI to weigh up the benefits against the potential harms when they're making their advice. And it's a difficult job, I'm sure, but I think certainly from my own point of view and all the teams that I'm aware of, what they've put out to the moment is excellent advice. Just as perhaps a little bit of a side issue maybe as well, the idea of additional vaccine doses for kidney patients is not something as new and crazy as you might think. Anybody who's been working up towards starting hemodialysis will or should have had a hepatitis B vaccination, and that program of hepatitis V vaccine does involve a much bigger dose for kidney patients than it would do for somebody who hasn't got kidney problems. So it's not as new an idea as some people might think. Next slide, please, Mark. So that's moving on to the booster vaccines now. This is a much wider plan, which I'm sure you've read about in the press as well. This is it's going to affect lots and lots of people. For example, it's going back to the early phases of the vaccination program. So anybody over 50 years old is going to be offered a booster vaccine, and particularly important for those of you on the meeting now, household contacts of immunosuppressed patients will be offered a booster vaccine as well. The sort of principle is similar to the third primary dose in that we figure that the immune system will lose some memory over time, and the best way of describing that is that you may get less antibody production over time as the immune system just almost forgets what it's been told. And the theory is that may mean that your immune system is less effective at responding to infection with coronavirus. So by giving a booster vaccination, it's a bit of a wake-up call for the immune system to start making some more antibodies so that you're primed for action if you do encounter the infection. Next slide, please. So for patients who've got kidney disease or kidney transplant patients, the current plan is that they'll be offered a booster jab roughly around 6 months after their third primary dose. Your nephrology and transplant multidisciplinary teams will also be getting jabs. I'm sure Mike's had his, I've had mine a few weeks ago. So it is a much wider program. And even booster vaccines is not as new an idea as perhaps you may think. Anybody who had a pneumonia vaccine in the past, and lots of kidney patients will be given a booster jab for pneumonia as well, just to give you that extra layer of help for the immune system after 5 or 10 years from memory. So again, not a completely new idea. And the next slide, please. So sorry about, it's a bit of a busy slide this one, so I just wanted to cram in some stuff. So we're looking at which vaccine are people going to get for their third and booster doses. The current plan is it'll be the Pfizer-BioNTech vaccine, which I'm sure you've heard of. There was also a similar Moderna vaccine, which has potentially been listed as an option as well. And that will be the option irrespective of what jab you had for dose 1 and dose 2. So if you had the AstraZeneca Oxford vaccine for 1 and 2, it'll be the Pfizer-BioNTech one that you'll be getting for the 3rd and booster doses. For those of you that don't know, the Pfizer-BioNTech and Moderna vaccines are messenger RNA, the mRNA vaccines. So what that basically means is the actual genetic code for that famous spike protein that's on the surface of the coronavirus, or a proportion of that spike protein, is what the vaccine is made up of. So that vaccine is delivered, and that genetic code instructs your own body to actually make that little bit of the spike protein, which then triggers your immune system to actually make antibodies against that in the future to give you that protection. The messenger RNA vaccines are not live vaccines. I'm sure you know that anyway, but just to reinforce that. And as far as safety, I think the Pfizer-BioNTech vaccine and vaccine in general, to be honest, have got excellent safety records. As far as the question as to why they're using Pfizer-BioNTech rather than other ones, my understanding from what I can read is that there is a bit more published evidence in using these vaccines as boosters, and they've sort of demonstrated immune system response is quite strong with those. It may well be that other vaccines join them in the future as more evidence emerges, but at the moment it's the mRNA ones we're going to be using. There will be an alternative plan, so if somebody has had some severe complications potentially with the Pfizer-BioNTech vaccine, there will be a plan B. I would imagine that would mostly be the AstraZeneca vaccine as the 3rd or booster vaccine. And next slide, please, Mark. That's just a bit of a diagram. It hasn't copied particularly well, actually, but again, I'm happy for everyone to have the slides after the meeting, but that just gives a little bit of an infographic as to how the mRNA vaccines work if you not familiar with them. So next slide, please, Mark. And I said one of the main questions tonight might be as to when and where we get in the 3rd doses of vaccines and booster vaccines. The 3rd dose rollout is in progress. Nephrology and transplant teams have given lists of eligible patients to the mass vaccinations teams in each health board. Dose 3 is the advice is to have that at least 8 weeks after dose 2, which I suspect most patients with kidney disease or kidney transplant patients, that'll be a lot longer than 8 weeks because you would have had your 2nd jab a little while ago now. A little bit of a caveat there as far as the 3rd dose goes is to consider shifting the timing of that to avoid periods of intense immunosuppression. So, for example, somebody in the early stages of a transplant, it may well be that we'd hold off that 3rd dose for a little while they're in the early stages after the transplant when they're on a fairly hefty immunosuppression medicine load. Also, patients that are on things like intravenous rituximab or cyclophosphamide, if there's a treatment plan in progress, we've got to kind of weigh the risks and benefits of starting treatment versus getting the vaccine in first. And it may well be that they'll try and give the vaccine a little bit later once the initial effects of the treatment have worn off. But that's very much a case-by-case individual discussion to have with your teams if these things are going to affect you as individuals. Next slide, please, Mark. And then as far as where then, so the current plan is for the majority of the 3rd doses to be given at max vaccination centres or the smaller pop-up centres that are going to be appearing as well. GP practices are going to have a more minor role compared to the earlier phases. I think my understanding is that that's probably because they want the GPs to be getting on with GP work rather than vaccinations now that you've got really good mass vaccination teams in place. And it'll be the mass vaccination teams that will be contacting individuals to arrange the appointments for the 3rd vaccine dose. For hemodialysis unit patients, I know that certainly in my patch in Cardiff and Vale, etc., the mass vaccination teams did start to visit the dialysis units towards the end of the 1st phase of vaccinations. That may well continue for the 3rd and booster doses. I know some other places in Wales as well, the actual staff of the unit were given vaccinations as well. So I would imagine that could continue as well. And booster vaccines, from what we know, there's going to be a similar plan for the booster vaccines as well. So everything I said about the 3rd vaccine will pretty much hold true for the booster vaccines as well. Next slide, please. So we're almost at the end now of my slides, which is great. I just thought it may be worth thinking about a few ideas for the future now, just to get the old grey matter thinking for the longer term. Personally, and I think there is people are thinking now that it may well be that having booster COVID-19 vaccines is going to be more of a long-term plan, perhaps alongside your annual flu jabs maybe. I think it's getting clearer that this SARS-CoV-2 virus isn't going to go away. It's going to become endemic alongside the other respiratory viruses that we deal with on a regular basis, whether that be things like RSV, things like flu, rhinovirus, and other coronaviruses. There are plenty of other coronaviruses that cause coughs and colds. So it may well be that it'll just flatten alongside those. So the need for booster vaccines may well continue longer term. The actual vaccine formulations may be improved. If you add things called adjuvants into vaccines, you can make them better assimilate to the immune system to get a really powerful immune response. Probably less likely that we'll need brand new COVID-19 vaccines. At the moment, we're using the same ones we used at the start. Coronaviruses don't mutate with the same sort of frequency and scale as influenza virus. So at the moment, it certainly appears that you're less likely to need to have a whole new vaccine each year as we do with flu. But I guess like with everything at the moment, it is a case of watch this space for any updated advice from the JCVI. Next and final slide. Thank you, Mark. So is there any questions, thoughts or ideas? More than welcome, and thank you very much for listening.
Thanks, Rob. That was a really comprehensive overview of a very complex subject matter. So I think looking at the questions that we've had from delegates before the webinar and the ones that have been coming through the Q&A box, I think it's worth just revisiting some of those key points that you've made. And I'd like to invite Mike Stevens into the panel just to sort of go over some of these questions so that we are we're making sure that we're answering them effectively for the individuals. So if I take the ones that came through the Q&A box first, I think one of them is a very easy answer, which I think you gave the answer to already, Rob, which was people want to see the presentations. So if that could be circulated after the webinar, that would be incredibly helpful. I do appreciate that sometimes a presentation without the narrative that goes with it can be a little difficult to navigate, but I think it was such a well put together presentation that will be very useful for people to reflect on. So some of the key questions that have been posed have been around, I guess, some confusion about terminology between booster and third primary dose. And I wonder if it would be useful just to spend a moment to just reassure people that sometimes the language seems to be getting used interchangeably, but the key message is another 2 doses is the factor that people need to take home from this. So Mike, perhaps you could explain that in more detail.
Yeah, this is definitely a confusing area, and actually a lot of our staff even have been confused about this. We've had to do a bit of education of our own teams on this over the last couple of weeks. So the third dose concept sort of was introduced after people had already been talking about the booster, so it's got quite confusing. As you say, and as Rob explained in his presentation, it's exactly the same vaccine. So the booster and the third dose, it's the same thing. So you don't have to worry if you've already had a third dose and they called it a booster at the time. It doesn't matter. It's the same actual vaccine. The way I think about this is that for some patients, either because they're on drugs that lower their immune system or because they've got illnesses that lower their immune system, they don't form antibodies so well to things like vaccines. And instead of 2 doses of a vaccine, a third dose will help them to make more antibodies. So that's the primary response to the vaccination. And that's where this third primary dose idea came from. The booster dose is slightly different in that it's designed to give a boost to your previous response to it. So as months go by, as years go by, your antibody levels drop a little bit. And if you measure them for COVID, it looks like after about sort of 8 or 10 months, there's a slight decline in the antibody levels in our blood when we've either had COVID before or we've been vaccinated. So we can boost the immune system there by giving another dose, another shot. And that's relevant for everybody in the population, actually. The whole population would benefit from boosters. The process at the moment is only for those who are the sort of higher risk or are exposed or more likely to be exposed to it, like healthcare workers. So it's a slightly different concept, but it's the important thing to remember is it's exactly the same vaccine you've had. So if you've already been called for, they told you it was the booster, you've had it, don't worry, it's not a problem. That's your 3rd dose. You will then be invited 6 months later, roughly 6 months later, for your 4th dose, which strictly speaking is the booster. Hopefully that makes sense. I know it is confusing though.
Yeah, thank you, Mike. I think that's a really helpful overview. As I say, the key take-home message is another 2 doses. So excellent. Just on that, one of the questions has been around the annual flu jab. A, is it safe for renal patients? And secondly, can it be given at the same time as whichever we're talking about in terms of booster or 3rd primary dose?
Yeah, yes, absolutely. It's safe. It's really important to have a flu vaccine this year because we think we may have quite a bad flu season. We don't know for sure. It's always guessing when it comes to this, but we think it might be quite a bad flu season. So definitely get your flu vaccine. You can have it absolutely at the same time. You can have a jab of flu vaccine in one arm and your COVID in the other. You can have it at different times. It doesn't matter. So don't worry about when you get your flu in relation to your COVID jab. Just get them both.
Yeah, I completely agree with that. I think, Mike, from what I've heard, I think in practice, some of them are not going to be given at the same time, but that's not because they can't be. It's just the practicalities of what they got available in the mass vac centres. So if you have the chance to get both together, as I had, get them both done, I would. But if they say we can't give you the flu today, that's also fine, but you can have it done with the GP. So it may be that people will go to the mass vaccination centre for the COVID and then to the GP perhaps for their flu.
Yeah, there was a slight delay in the flu vaccine arriving this year. So if you got your 3rd dose early, you may have missed out on the flu vaccine because they may not have had it in the centre at the time. But that's not a problem either. But just make sure you still get your flu jab if you haven't had it.
Excellent. Thank you for that. One of the questions that's been posed is around sort of timings in terms of is there a sort of cut-off date where people should have received their invites for both of their additional doses? And so if there is a cut-off date, at what point should they be saying, I think I might have been forgotten about, and what the actions they need to take in order to make sure that they are fully covered?
Yeah, this is probably the most important question of the evening for me, because I think a lot of people are wondering what is happening because they haven't heard anything. So first thing I'd say is that there hasn't been any timeframes set for this. Now, you may have seen from England that they did issue some dates, and they said that everybody would be invited by a certain date. I think that was brave of them, but anyway, we haven't done that in Wales. There is no set dates. What I can say is that we've worked really hard as a clinical team to make sure you've all had your names put forward for the vaccinations, and I know that this has caused a bit of angst, because when patients have been phoning their GPs or even phoning the vaccination centre, sometimes they're finding that they don't have any record that you are down and eligible for either a third dose or a booster in some cases. But I can assure you that we've done this at a national level in Wales for renal patients. So we've really carefully gone through all of our patient lists, and we've submitted every single patient who's under the care of the renal teams in any unit in Wales. We've put your name forward to the central vaccination team, and the central vaccination team hold that data then. And it's important it goes that way, because this is going to be a long-standing thing. I think somebody asked in the questions what's going to happen in the future, and we're expecting this to be an annual thing from now on, maybe even more than annual, who knows, but we definitely expect that we're going to need boosters again in the future. So getting this process right now and having a central way of doing it is really important. So we've put all the names forward to the central team, and the central team then are putting a sort of sending this information out to local centres so that you don't have to come to Cardiff, for example, if you live in Pontypool. They will organise you to have vaccines at the most convenient site for you. But that part of it is taking a little bit of time. So there is a little bit of a delay. I can assure you all the lists have gone. So you are on the list if you're a kidney patient and you're eligible, but it hasn't filtered all the way through, particularly to your GPs, actually. So I wouldn't contact your GPs for information about this, because they aren't so involved in it this time round. They were absolutely instrumental to the first when we were vaccinating, when we started, December last year. But they aren't so involved in this time, except in certain areas, some of the more rural areas, and for some specialist groups. They are helping, but mostly this is being done by the vaccination teams. But even the local vaccination teams in some areas, the names haven't quite filtered through yet. Don't worry, your name is on the list and it will happen. The process is, it's different. I suppose it may be helpful if people understand why it's different this time. When we were trying to get everybody vaccinated back at the beginning of the year, we knew the entire population were going to be vaccinated then, and we also knew we had big teams of people doing it all over the place. All of the local sports centres and GP practices and everywhere else was converted into vaccination centres. Massive numbers of NHS staff diverted from their normal duties to become vaccinators. So there wasn't a need to be really refined about the lists of patients that went. We wanted, as a kidney team, we wanted to get our patients vaccinated as quickly as we could, and some places, the teams actually just went and did it themselves in North Wales and Southwest Wales. The teams just went out and vaccinated their own dialysis populations because they wanted to make sure it would happen. But we also knew everyone was going to get vaccinated. This is different this time, because not the whole population is not going to be offered a booster, and they're certainly not going to be offered the third primary dose. So we have to be going through in a more careful way to put patients forward. Just to confuse things even further, they changed the rules after we'd already started this process. So the original guidance was that it was really just transplant patients or patients who were on other drugs that lower your immune system. They then changed it a couple of weeks later, after some canvassing really from the renal community, to also include dialysis patients and patients on the transplant list. So we ended with kind of a slightly piecemeal approach to it, all done for the right reasons. We're still learning all of this. This is brand new to us, and we're trying to get it right, and we will get it right. I'm really confident about that. But be reassured, your name has gone forward and it's going to happen.
Great, thanks, Mike. On that point, somebody's just popped into the Q&A about patients who live in the cross-border area. So is it the case that the list has been driven by renal unit that the patient is receiving their care and support from, rather than the GP practice they are registered with?
Yes, that's how we've done it. So if you have your care in a Welsh kidney unit, then we have put your name forward to the Welsh vaccination teams. Now, if you're just on the other side of the border, you may actually have already had your name put forward via other means, like the GPs, for example. There's also extra safeguards that they're put in place. The Welsh government have a variety of different ways of pulling out which patients they think are immunosuppressed. So there's lots of different, you know, they keep sending me another list of patients saying, are these patients immunosuppressed? And we have to look through them and see. So I think probably many of you have had your name put forward about 5 times now from various different sources, which we're fine with. We'd rather that than we miss anybody. But we're pretty confident that we haven't missed people, although I do appreciate that it may not yet have got back to you as the patients, and certainly even actually some of the local vaccination centres, it hasn't quite filtered through yet exactly which patients need to be receiving their 3rd dose in particular.
So is the key message that if anybody has any concerns at all, they have been missed, which is highly unlikely given the explanation that you've given. But if they do have concerns, to speak to their kidney care team, who will then be able to sort of advocate on their behalf and look into what the situation might be.
Yeah, I think that's the sensible approach. I wouldn't go to your GPs because they won't necessarily know yet. And actually the local vaccination centres, if they've got your name, they've probably will already be in touch with you. So if you haven't heard from them, they probably haven't quite got that details yet. But if you're anxious about it, you can contact your local kidney units. We've just written to our patients in South East Wales, so anyone who's looked after from the Cardiff units, to give them that information and some contact details. And we can just double check that your name was on the list that we submitted, and that will just provide you some reassurance. And I have been already doing that the last couple of weeks with patients who've contacted us.
Great, thank you. And I think probably just one last question on the vaccination rollout itself. You've already touched on the fact that the chances are this is going to be at least an annual event in regards to boosters. Is there any research that is being undertaken at the moment to look particularly at the immunosuppressed members of the community, and really what is the ideal time frame between boosters in order to maximise protection?
Yeah, so, you know, the most researched topic in the world, I would say, in the last 12 months, COVID, and certainly immunosuppressed patients, or anyone who's got an immune system that is affected by illness, they are being studied. But of course, studies take time to produce their results, so we don't have all of the information yet. What we do know is what we were expecting to see, which is that if your immune system has been dampened for one reason or another, because you're taking medication, or because you've got some kind of condition that means your immune system doesn't work so well, you don't produce antibodies as well as someone who isn't on those medications. And, you know, that's what we would expect to happen. That's what we were expecting to happen with this. And we also know from some early studies that you can improve those antibody levels by giving a 3rd dose. And that's the reason why that's what's been advised. Now, the fact that you don't have as many antibodies or as high level of antibodies after being vaccinated doesn't mean you're not protected. So there's lots of really good evidence, and some good evidence actually from the UK, that just looking at outcomes for patients, and not looking so much at antibody levels, we've got some of that data as well, but just looking at what happens to people. And what we know is that if you've had 2 doses of vaccine and you are a patient who is on the transplant list or has had a transplant, you are far, far, far less likely to get seriously unwell if you get COVID. So you're less likely to get COVID and you're less likely to get seriously unwell from it. So, you know, and it's a really significant drop. So these vaccines are working for our patients. These are working for you as patients. It's probably not working quite as well as it is for the general population. And that's where hopefully this third dose will make a difference. But it is, if you've been vaccinated, you are in a much better position than you were this time last year.
Right.
I just had a thought as well there. I know, just reading some of the JCVI stuff, what they've said is that in the very broad classification of what is immunosuppression, they think that the protection against serious illness, hospitalization, etc., is almost right up there with 95%. But the big caveat is there is lots of different levels of immunosuppression. So I think there's different patient groups, whether it be rheumatology, neurology, nephrology, and transplant, and different medicines as well. So I think a lot of the ongoing research is to try to look at individual patient groups and individual types of medicines to define those issues around who is the most high risk of not responding as well. And that's a lot of ongoing research. And that, I suppose, is going to come out in the next 6 to 12 months, isn't it? So we can really define within rheumatology, neurology, gastroenterology, nephrology, and transplant, which are the particularly difficult medicines. I mean, I think at the moment, some of the focus is on medicines that affect B-cell production. So that seems to be mentioned a lot as those are the medicines that there's a bit more concern about. But that might be, again, like Mike said, that's just because they're looking at antibody production. Vaccines do much, much more than helping make antibodies. It's a broad immune response. It's not just antibodies. So even if antibody levels are low in an individual, that, as Mike said, that doesn't mean you're not protected. It just means that's the only measure we've got at the moment of a sort of a biochemical or blood test. That's the only way we can measure vaccine response at the moment.
And so the key message is that there's a lot of research going on. They are also looking specifically at the needs of the kidney population, as well as the wider immunosuppressed population, and adjustments will no doubt be made as that research starts to really give some clear indications as to when boosters need to be provided to the various populations. That's really reassuring that all that work's going on in the background to make sure patients stay as safe as possible. All right, so I think on everybody's minds as well is just how do we return to some degree of normality? There's questions about traveling abroad. There's questions about how individuals maximize their safety during winter months, which we know is going to be probably quite a difficult winter this year. Are there any sort of top tips and advice that either yourself, Mike, or Rob can give to the delegates in that regard?
Yeah, I mean, it's a difficult one, isn't it? Because it's so personal, this, and what I've said throughout COVID is that this is really about understanding as much as we can about where we are right now, and then people making choices that fit with their lives. So by that, what I mean is that if you really want to do something, then if you've got an idea about what the risk of doing that is, then you can make a call. And I would be encouraging people to just think, is there an alternative option that is lower risk to you? And when we were talking at various Q&A sessions we've done over the last 18 months or so, give an example of, if you really need a night out, you really want to have a night out. If you go to the local pub with 100 people, most of whom you don't know, who won't have been screened, who probably aren't wearing masks, and you can't socially distance, and the circulation of air is not good, that is a pretty high risk environment. You would be better to choose an activity that is less risky, like maybe going to a friend's house where you know them and you can be reassured that they will tell you if they have symptoms. Maybe they could do some testing before you went there if they were being really helpful to you. Or you could go to something that was involved being outside. If you want to go to an activity, you know, and you had somebody ask me the other day, I want to go to, I've got some things planned, I've got some gigs to go to, and I want to go to the Autumn Internationals. Well, you know, I would say that the Autumn Internationals are pretty low risk, to be perfectly honest. You're going to be in an outdoor stadium. The Welsh government have said that people have to be screened before they come in terms of showing a vaccine passport or negative test. So I would consider that environment relatively low risk. I think gigs are a little bit higher risk because of the environment. It's a closed environment, and you probably will be less reassured by the other people who are going to that. At least you're not going to know who they are. So I think this is about making choices that are as lower risk to you as you consider reasonable, and just think, is there an alternative, and can I get as much enjoyment out of that alternative, and go for it. We are definitely in a much lower risk situation than we were a year ago, and there's other positive stuff around as well in terms of newer treatments that are being investigated, and you can imagine the entire world is looking for some cures for these things, treatments for them, so ways of preventing us getting them. So we're going to have, this time next year, I expect we'll be in a better situation again. So it's been pretty miserable. You know, we all know that, and kidney patients have fared very badly throughout all of this, and transplant patients having to lock themselves away and things. This is not what things are going to be in the future.
And foreign travel, would the same advice apply in regards to thinking carefully about areas that you might want to travel to in terms of what their COVID security measures are, etc.?
Yeah, I think so. I mean, another thing that it's trying to pick your timing as best you can. You know, it looks like probably in Wales, you know, last week was probably the peak of our current wave, and that's what we were expecting based on the predictions. We don't know this for sure, and it may well go down and then come back up again. But you may be able to pick your timing if you are going to be going away. I think actually being away is less of an issue. Getting there is probably more relevant. If you're going to be going on a plane and things, that's probably the risk part of travel at the moment. But given that what we know is that as a high proportion of the population have been vaccinated, if you know you've been vaccinated, you will be more protected than you were if you hadn't been. Those things are reasonably reassuring. I would still be asking the question, and for me personally, and for my family, I made the decision this year, we're not going to go away. We're not going to go overseas, because it's a risk that for me personally, I don't need that. I'm happy with a breakaway in the UK and area that I know, but I know other people feel differently. It's really important to a lot of people to get away to Spain for a week or a fortnight, which is fine. That's your personal call about it. But just think, can I wait a bit? Can I do it in a different way? That's what the advice I would give. Rob, what do you think?
I think you're absolutely right. I agree with everything you said, Mike. And I think even if you're abroad, it's the kind of activities as well, isn't it? So if you're going somewhere and it's nice weather and you're spending most of the time outside, that we know the ventilation and fresh air is a massive issue, because that waters down any virus that's flying around anyways. You can't compare being in a sweaty nightclub to being out in the fresh air on the beach somewhere. It's a very different area, isn't it? So I think everything you said about what you do locally, I think that would apply to going on holiday as well. I mean, Europe, if you're looking at Europe, most of the vaccination rates in Europe are at least as good as the UK. So you can look at what countries are doing well with that. I mean, most of Europe is good, isn't it? So perhaps that's worth checking out for the individual country that you're looking at, just to see what their vaccination rates are like. That give an indication of how much virus risk is there, I suspect. But I think Europe is pretty good at the moment.
Okay, that's really helpful. I'm just getting a little conscious of time. I think we covered most of the questions. At least I hope I have most that have popped up in the Q&A.
I think, sorry, Susan, Helen asked a question there about family members and whether they get booster vaccines.
Excellent, that's a good, yes.
The JCVI advice is that if you are a family member of somebody who is in the high risk group, then they should receive their booster vaccines. That's not the third dose; it's the booster vaccines. Rob, I think it's age 16 and above, isn't it? Helen's daughter's 17. So I think it's 16 and above for the recommendation of the boosters.
Pretty sure I've got it here. If you give me a sec, I've got the JCVI stuff here, just in case I needed it for reference.
Rob,
those household contacts age 16 and over. Yeah.
So Helen, yes, your daughter is allowed the third dose. There's actually a self-referral form for household contacts to do. You can find it on the Welsh Government website. And you just fill it in and they will organise it for you. You just say you're a household member with somebody who's vulnerable, and they'll sort it out.
Excellent. And is there a time frame that is recommended since the last dose that they received, their second primary dose?
Well, 6 months is the time that they've been saying for boosters. So if you're within the 6 month window, what we think at least is you don't need it. You should have good protection from the first 2 doses from your primary course of of vaccination within at least 6 months. It's probably actually a little bit longer than that.
Yeah. So I would agree with that. I think 6 months is a nice easy figure, isn't it? But you probably, if you've got a fully functioning immune system, no medicines or health issues, then it probably does last longer. But 6 months is a nice, easy to understand figure, isn't it? And easy to sort out, I think.
I think there's a few more more nuanced questions coming up, some more specific questions coming up in the chat. Unfortunately, I can't see them on my device. I can only see the questions that have gone into the Q&A. But what I would say to everybody that all of the questions that were provided before the webinar and those that have been posed during the webinar, both Q&A and the chat box, will be looked at, and a response will be provided, and that will be available as part of the package of information that is going to be issued by our charity partners who have made this webinar possible. I think, unless there's any final tips that either Mike or Rob want to add at this point that they felt hasn't been covered.
There's a couple of questions there. If we've got a couple of minutes, they about does the level of immunosuppression drop longer you've been on the drugs? I.e., if you've been a transplant patient for a long period of time, does that affect all of this? We don't know the answer to that. What evidence we do have is that it doesn't seem to be making a difference. In other words, it's not, if you've been on these drugs for 20 years, you're not less likely to get a response from them than if you've only been on it for 6 months. The only exception to that is that if you are brand newly transplanted, so if you've had your transplant in the last couple of months, that's probably not the best time to get vaccinated, because that's at the point when your immune system is at its lowest after a transplant. So we give you some really powerful drugs when you're in the operating theatre and for the first few days afterwards that really do lower your immune system. So it's not sensible to get a vaccine within the first couple of months after a new transplant. But beyond that, it doesn't, as far as we know, at least, it doesn't seem to make any difference.
All right. Now, I just saw another question pop into the Q&A, and it's probably quite pertinent given the amount of publicity that's been in regards to school-age children and the amount of COVID that is circulating in the schools. So it's an individual who's a transplanted patient who's got a child of school age. Is there any additional concerns or actions they need to take in order to enhance their protection?
Yeah, I think children's age less than 16, the dosage recommendation is slightly different, and I think they're recommending 1 dose, Rob, aren't they, rather than 2
yeah,
for that group.
I think the current rollout to those 12 to 15 or whatever is just 1 dose at the moment, isn't it?
I think these are difficult questions, and Jeremy's comment there about the, I think Helen's earlier on as well about the so much COVID in schools and things. It's really difficult because we are expecting a big proportion of the population to get COVID at some point now. That's effectively what our approach is, because we haven't got any other approach. We can't lock ourselves away forever. It's just not practical. So everything from now on is about minimizing the effects if you get it. I would still be trying to avoid getting it right now, because it can still be a very nasty illness, particularly if you are an immunosuppressed patient. But I don't think we are at the point where you have to lock yourself away anymore. I really don't. I think that you get yourself vaccinated, try and minimize your risks as best you can by choosing activities that mean you surround yourselves with people that you know and trust as much as you can. Try and keep yourself in well-ventilated areas if that's possible to do. And I think that's the best way of keeping yourself safe. You can't keep your kids off school. I don't think along those lines. The children need to go and get their education. People need to do their things. Consider whether or not you want your children to be vaccinated. It's, the offer is there for age over 12 now. You can get vaccines. All children aged over 12 can be vaccinated now. It's not just those who are household contacts. This is about trying to manage risk rather than eliminating it completely.
Yeah, I agree. I don't think these are sort of things you can never completely reduce risk, but I think if you consider that the vast majority of the population of the UK has either had COVID and or a vaccine, or they've got some natural immunity to it anyway, or they've had some other recent coronavirus type infection which gives them some protection, means that as time goes on there will be less virus around, because if people have got some immunity to it, even if they pick up the virus, because having a vaccine doesn't stop you getting it, it just means your body reacts quickly to get rid of it. So there's less virus circulating. I think that's the best way of describing it, because a combination of high levels of infection and high levels of vaccination. So yeah, you're right. We're in a much better position than we were 12 or 18 months ago. So I think if your kids need vaccination, I would advise getting it done. I've got a 15-year-old who's actually unfortunately now home with COVID, but she would due a vaccine tomorrow, but she would have had it. I don't necessarily think at the moment they need anything extra. I think follow what the JCVI say about, over 16s can have the booster. Otherwise, I think follow what their advice is for the moment. And it may change again. The JCVI, to be fair, they're happy to act on evidence as it appears, aren't they, Mike? So they'll go with that. I think a lot of the JCVI advice, it's kind of shifting from basic pandemic management to sort of political decisions now as well, isn't it? It's a little bit different now, isn't it? Because we've moved on from being high risk, crazy pandemic situation to what's the longer term plan. And there's an element of choice and politics around that as well, I think. So they shouldn't be forced into making advice. They can advise on what they think is the best available evidence, and it's up to the politicians to decide how they implement that, particularly for youngsters, isn't it? That seems to be the case.
Yeah, I thank you very much. I can see the first line of a couple of chat messages coming up with people saying thank you for time to explain everything in such a reassuring and informed way. So I'm going to bring the Q&A to a close. As I said earlier, there is going to be a sort of comprehensive Q&A available for all the questions we did answer and those that we didn't have the opportunity to get to in the time allowed. So if I could just thank particularly Mike and Rob for presenting and also providing, as I say, such clear information to everybody. I'm sure it makes a massive difference to people's confidence and how they manage their lives moving forward. But also I'd like to thank the kidney charities, Paul Popham, Kidney Wales and Kidney Care UK for making this possible to have the webinars, and also the technical staff behind the scenes that have made things move in such a seamless way. So thank you to everybody, and I'd like to wish everybody a really pleasant evening. Thank you.